the Trust Board meeting in public. First of all, we have apologies from Parish Patel for this meeting. And also welcome first to Amanda Federo as Associate NED to her first public board meeting. Welcome, Amanda. And to Imran Devji, who's joined us as Interim Chief Operating Officer. Welcome to you both. This is also a notable meeting in that it's Adrian's last public board meeting. So Adrian, I just wanted to say there'll be opportunities nearer the time of your departure, but I just wanted to say on behalf of the board, a heartfelt thank you for the outstanding work that you've done in the Trust. I know it's widely appreciated, not just at the board, but all the way through the organisation. You will certainly be missed, and I know everyone wants to say their thank yous to you for everything that you've done, but I know there's a little time for you to go yet, but I wanted just to put that on record.
Well, Steve, thank you very much indeed. That's very kind. I'm proud to have been part of this team, proud to be part of the organisation, delighted with the successful journey we've been on together, and I really appreciate those kind words. Thank you.
Okay, there are no declarations of interest. Can I check with people that you're happy with the minutes of the meeting held on the 2nd of June? I'll take silence as agreement. There are no matters arising. So shall we move straight to the board assurance framework? Lynette?
Okay, thank you. So this is the first time we've received the new format of the board assurance framework at board, although colleagues would have all seen it at subcommittees. It's divided into 3 sections. So the first page provides a high-level overview. The second is the heat map of the residual risk against each objective. And then it goes on to give details of each of the 9 individual risks, and it links to the high-level risk register. This was the first draft, and the feedback, I wasn't at all the committees, but the feedback I think is positive, although of course, there's more that we can do in terms of strengthening actions. We will be considering BAF and the risk registers at our seminar in September, so that's the opportunity perhaps for us to look at things like risk appetite in a bit more detail there. In terms of the 9 individual risks, the only one I'm really going to mention, but exec colleagues may want to say something about any of the others, is around BAF 5, which is a new risk that was added in relation to the risk assessments for staff in relation to COVID. And just to say there's been an awful lot of progress on that since the risk was added to the BAF. And I'm sure Monica can update a bit more later in the meeting, but it's just to say that that one was very much a very draft when we added it to the BAF. So that's what I'm going to say. I'm happy to take any questions or any other comments.
Thanks, Lynette. Miranda? Miranda?
I am here, sorry, I just had trouble unmuting.
Okay, did you have a question, Miranda? You've muted yourself again.
Sorry about that. I like the clarity of the new format. My only question is really, if you look at the overall summary of the organisation, in other organisations where I've worked, from time to time we have kind of taken a sense check of whether the overall risk as shown in similar documents is how it feels to work here. And I suppose the one thing I wondered about was looking at this, whether it really feels as though there is that much red in this organisation.
Interesting question.
Does it feel like that kind of place,
Adrian.
Thanks, Steve. And it's a good point that Miranda makes. I think going through the way that the risk levels are calculated, actually, I think, particularly at the moment, given the pressures that the organisation has been through, the challenge that we faced with COVID, issues around that, I think they are a reflection. When you take, they are a product, of course, of the likelihood of the risk occurring and the impact of the risk should it occur. What's mostly in our control is reducing the likelihood of the risk occurring. There will always be an impact should it occur. I think in the chart, red is described as extreme risk, which is a big word. And I think probably I wouldn't use the word extreme to describe the risks, but I would agree with the rating that's been given in terms of likelihood of occurrence at the moment. But I agree with the point, Miranda, about the clarity of this, the actions that are in hand, the work that we're doing. I do think this is the first time around all the committees and the board. We'll be going back through it in detail as an executive team, taking all of the comments of the board and the board committees into account, and there will no doubt be a revised version as a consequence of that.
Thanks, Adrian. Jackie.
Thank you. We did look at this in the quality and safety, and would like BAF2 to be also part of that committee's remit. The BAF2 sort of reads more as the financial impact of COVID, where there could be a quality impact. We really liked the new format, and I think it was just to make sure that we stay focused on the corporate risk register and how that links into the BAF, and having some sight on the process of that. Other than that, the controls, are explicit, which is good, which we like.
Yeah. Great. Okay, thanks for that. Thanks, Lynette. And I know there's been a lot of work involved with yourself and Pete and Nikki and others in working up the new format. So as colleagues have said, it's a live document, isn't it? We'll keep working with it and through it. So that's good. Thank you. Shall we move on to the Chief Exec's report, Adrian?
Yep, thank you, Steve. And in the report, I've tried to strike a balance between highlighting the fact that while COVID is, of course, the dominant issue for us all at the moment, other things have been continuing, must continue, and of course we're working through the restoration and recovery phase at the moment. But there are things which are still of concern to people. So, for example, under quality and safety, the importance of the visiting arrangements, which we are continuing to have to flex according to the situation on any particular ward and the situation with regard to COVID risk in any particular place. But we are aware of how important visiting is to patients and their families. And indeed, at the moment, for example, at the Rye Memorial Hospital, one of our intermediate units, where I was yesterday, we're not allowing visiting on the ward because it was being protected as a safe area, but visitors are coming to the windows to talk to their relatives through the windows. So across the organisation, members of staff are making what arrangement they can to obviate the problem of visiting. Other issues are continuing. So, for example, the work that's been done on transition, which Vicky is leading and sharing across our system for us, the improvement work that we're doing on our discharge arrangements, the measures that we continue to track on safeguarding. And this month, for example, we had the report from our Looked After Children team and the work they've been doing, the importance of that work to make sure that they're maintaining contact with children who are looked after in foster homes or adopted care to ensure their well-being. And we're relaunching some of our transformation programs. So, for example, the stated aim of this trust being the Best at Frailty. That is now restarting with energy. We've made a terrific new appointment to our frailty consultant team, and David Walker's our executive sponsor for that. In terms of people and leadership, we had our education steering group yesterday. Across the board, we've been looking at how we manage continued education through this period. So over 500 staff have been seconded, and all of them have found richness and value in the learning they've had from there. We've had the challenge of nurses from overseas taking their OSCEs, their certifications of competence and registration in this country. Those are restarting now, and we've got people booked to go through those in September. We had a cohort of medical students who volunteered to come to us just prior to graduating this summer, and we're now taking on board our foundation year doctors. Delighted to welcome them to the trust. And of course, the training of the more senior doctors and training grades continuing. So we've had a review of those. We're kicking off the programme that the board may remember. We've begun with Henley Business School, and we've got over 40 people in the trust who will be taking part in the leadership development, the Senior Masters Apprenticeship Programme with Henley Business School, and that's now set up to commence in November. So that is all in hand. Recruitment has continued throughout this epidemic, and in fact, applications for roles have improved. So we're seeing improved recruitment for people coming into some of our challenging areas. The emergency departments, for example, are now fully staffed. We've had a resurgence in applications for ITU, and actually we've made some successful appointments recently to occupational therapy and physiotherapy teams in the community. So that is working well. I've highlighted the communications and engagement, and I think this has been really important. Of course, everything's been really important, but the work that our team has done through the epidemic has been significant. I've come off a virtual visit this morning with one of our teams out in Uckfield and Lewis, and they were saying how valuable it has been to have the clarity of message, the consistent message, the regularity of briefing throughout the weeks and months of this pandemic, so that everybody knew what was going on across the trust, what their role was within the trust, how were they contributing to meeting the challenge that we were all facing. And a couple actually work for other organisations, and were favourably comparing our communications with them. So that's partly why I've just highlighted this in there, because in any situation of major incidents, one of the first casualties of any battle, as we know, is often communication and clarity of message. So it's great to see how much that has been there. Finance, and we will do a detailed finance report later on. I've highlighted it in this report just to make sure that people can see that in a succinct form at the front of the documents, but we will be going through the finance shortly. I guess one thing to particularly highlight is the capital. The achievement last year of significant capital spend, but the challenge for both the finance and the estates team of following and successfully prosecuting the various opportunities for additional capital that are coming through at the moment as part of the investment in the infrastructure that we're seeing, while managing the preparations for our major 500, 600 million pound investment over the next 5 to 10 years. And then finally, I've mentioned the strategic development and sustainability. We, as an executive team, had the debate at the start of the year about what are the key priorities for the trust this year. Actually, we gathered together the week before, or it might be the fortnight before lockdown happened. So it was one of the last occasions that we all sat around the table together in a full and debating capacity before the lockdown all happened. Clearly, those priorities have remained front of mind and will now build into the reshaping of our next 5 years strategy, which is coming back to the strategy committee. So I think those are the highlights I'd mention.
Great, thanks very much, Adrian. First question from Jackie.
Thanks. First of all, I suppose congratulations are in order to the Trust for everything that we've managed to do and do so well during this time. So I'd like to record my thanks for that. But I've got two questions. One is the preparation for winter and flu. With the release of vaccines, flu vaccines, what's our plan for staff vaccination? And my second question was about the plans for a revised quality walks that you mentioned, and when will they come to us? Those are my two questions.
Okay, thanks, Jackie. So, if Vicky wants to comment at any time, just raise a hand on the vaccination. But the aim, last year we did very well with our flu vaccinations. We had a high proportion of members of staff who we successfully vaccinated, one of the best in the country, actually. And the plan will be obviously this year the same, Jackie. So we're putting plans in place ready for that. The quality walks that are referred to in this report are specifically related to the medical education and medical training. So okay. It's not the board walks, board quality walks that we had. And of course, we're relabeling those as well. We will be introducing those. At the moment, it's still the case. And I know that all of my colleagues on the executive team, apart from Vicky and David, who are clinically engaged around the wards, are trying to strike the right balance between maintaining our personal and, if you like, in-presence support for teams across the organisation, while respecting the need for the minimum interaction and movement around the organisation because of infection prevention and control. So it's not yet at the stage, I think, where we would want to open up to visiting, but actually a brief discussion with Vicky this morning, I know that Vicky is very keen that non-executive directors are given the opportunity soon of coming back into the organisation to acquaint themselves with the way in which practice, working conditions, methods of prevention infection are changing things. And as we said at the last board, I know that's still happening from time to time. So, for example, with Paresh, he and I visited our district nurse teams a little while ago. I think Vicky has a hand up for that.
Thanks, Adrian. I'm sure Monica will want to talk about flu and all the amazing work that her teams and Nocky Health support. So I think in terms of flu, I think we've historically always had a really good uptake, and our staff have been amazing, very positive and very conscientious. I'm hoping that because of everything that has been going on and is still going on, that will increase even more, and probably we'll see that in the public, I suspect, I hope. And Adrian's right. I am very keen that in a safe way that we try and support some visits. I'm very happy to personally, not that you need escorting, but to go with you in PPE, and we can get scrubs and things if that would make people feel safer, that they can kind of leave COVID at work, and that's important, that you feel safe. But I've spoken to the chairman briefly as well, and I'm happy and keen that we do that, because I think there is it's very assuring, but also important that you kind of get a sense of what our new normal is like now, because it is really very different, I suspect, to the organisation that you kind of would have walked around a few months ago. And we probably forget that because we see it, some of us see it every day. So it's very quickly become our new normal, but I appreciate that's not the case for you. So I'm very happy, and I'll leave Steve to talk to you about if you would want to do that and how you would want to do that, but very happy to support that. And I know our staff, I'm sure, would like to see you, and I know that you'd like to see them, so so happy to do that.
Yeah, I think we'll definitely follow that up, Vicky, and you and I can talk outside about how we make that happen. Miranda?
Yes, I'd like to join others in congratulating the team on a very good performance in the first phase of this. I wondered if Adrian can say a little bit more about the contribution of junior doctors during the crisis so far. We heard a little bit about that at POD, and it was really quite interesting and inspirational to hear how they'd come through and they'd really risen to the challenge. So that was one thing. And then the second thing was there was a reference in your report, I think, to counselling for staff. I wondered what sort of take-up there had been on that.
Thanks, Miranda. And just as a heads up, Monica, I don't know whether you have the numbers for take-up of counselling. I don't have the numbers to hand, Miranda. So perhaps Monica has those in a second. But in terms of the junior doctors, and I think I'm right in saying it was about 13 or 14 doctors who came to us in February, March, volunteering to come early prior to the expected date of completion of their exams. I've met with several of them. David Walker may have done as well, and they were terrific in the commitment that they were making to support the work we were doing. And of course, they were finding the experience beneficial themselves. And I've reflected, Miranda, with several medical colleagues that when, I'm going to sound old now, that when we were young doctors at the end of our medical training, the early experience of doing locums, of doing practical work on the ward was commonplace, and that kind of had got lost over the years. And there was no doubt that the people that I met doing this were finding it helpful and learning from it, as well as being very valuable to us. There were a number of rota changes that were brought in, of course, to cope with the changed pattern of demand that we were seeing across the wards. So the surge rotas that were put up, actually relatively quickly, they were moved back to a different rota system, but everyone was very flexible, very willing, very compliant with doing that, which was good to see. In terms of the counselling, I think we have put a comprehensive suite of offerings in place. Monica, I don't know whether you have more detail on things like take-up of that.
In terms of the counselling, as you say, there's quite a range actually of different things we do. We do a number of interventions. We do something called Time to Talk, which is a helpline for staff that they can phone, and that's been particularly used by staff during the COVID pandemic period. And in terms of uptake, there's been hundreds of staff that have phoned that helpline actually. So that's been really important. We've got our ongoing employee assistance programme through occupational health, and again that's been used during this period. Also, we've started introducing some very detailed psychological support sessions for staff who have been through and worked on the front line, and again that's been well supported in different areas. And in addition to that, we've done some support for managers in terms of getting their staff back to work, maybe staff that have been chilled in, and again they've been very well supported. And we've carried on with the virtual sports rounds as well. So there has been a large number of different interventions, and they've all had very good support. And I can provide the actual numbers for all of those outside of this meeting if that would be helpful.
Great, thanks, Monica. Karen.
Thanks. So I would like to add my congratulations to the execs and the staff and everybody involved with the trust in the management of the first wave of COVID and managing the rest of the hospital operations at the same time. I have a couple of questions. One, Adrian, maybe from you, or maybe David and Vicky. I think it would be helpful to have some insights in terms of preparations for a second wave or surge, if it's not a full second wave. I think there's probably people are interested in just kind of knowing what is in place, particularly in terms of collaboration with care homes, because obviously that's a big risk in our area, and kind of how that integrates with the winter plan. And then my second question is, in your paper on the finance section, you mentioned that we're not approving any business cases at the moment. And I wondered whether you had insights into when that might change, and whether it's actually the process of approving business cases that is not allowed, or is it just simply that there's no funding for business cases at the moment? Thanks.
Thanks, Karen. If I kick off again, and delighted David and Vicky may want to contribute, and Joe from an operational, obviously, as well as Imran from any other aspect. But the preparations, I suppose, Karen, come down to 2 or 3 things. One, obviously, is our critical care capacity. That was the big issue for us as we went through the pandemic. Several people have mentioned the first phase as though a second phase is inevitable, and that's it's not inevitable. It's possible, but we shouldn't assume it will necessarily happen. And we have created additional critical care bed numbers. So we would normally run with 19 across the 2 acute hospitals. We're up to a staffed level of 24, 25, and with a number of other beds not staffed but mothballed, should we need to go back up to the 30 or 40 that would be required if a big peak came through. In terms of specifically, you mentioned relationships with care homes. We've put a lot of effort into that. It was something we had identified as important for us to do better prior to the epidemic, and even more so, of course, now. Every nursing and care home across the county has got a nominated contact. We've contributed to training on infection prevention and control, use of PPE. We've joined the weekly huddle that the Social Services County Council have with care homes, and that's been appreciated. And we're working on supporting the arrangements with primary care and community nursing team support into care homes. So the relationships there are important. And of course, the other side of preparations will also be making sure that we have the right policies, procedure, protocols in place. There's been a lot of learning through this period about the right way to treat patients who contract the disease and have serious complications of it, of course, and all of the work that's been done on PPE, infection prevention, control, and handling. So I think just off the top of my head, those are things I can see that David and Joe would both want to contribute. And then perhaps we'll come back to the finance in a second.
Joe?
So I'll keep it relatively high level. So as part of, and because a lot of this will probably be covered off through other papers as we go through. So through our recovery board, we've just changed the format slightly to look both at restoration and recovery, but also future planning. And we will pick up our COVID plan, which is just been, we have a draft COVID plan. We obviously had emergency plans in place and business continuity plans. There's been a review done across the organisation, and those plans are being updated at the moment. So that's being that will come through our recovery board, and the winter plan is also being tracked through our recovery board. And I'll say what I say every single year: it's either winter or we're planning for winter. And nothing else exists in our operational world. And so everything we are doing is planning for, if you're almost like the worst case scenario, and Imran is leading on that with the ADOs and the divisions and part of the system. So we've got our mechanisms through our recovery board, both for COVID specific and through winter. We're continually looking for how we could build additional capacity. And we continue to submit bids through to NHSE, either for trust-based capacity or wider system capacity. And the third phase letter, which we can share with you, which has come out yesterday from Simon Stevens, again has confirmed the first 6 weeks of care will be funded for continuing healthcare and social care patients. So it helps us keep our occupancy down. But I won't go into any more detail than that.
Thank you, David.
So just to support what Adrian has said, through the clinical advisory group and through the PPE groups and the infection control groups, we have protocols in place for the management of all patients with COVID or suspected COVID. We have stepped a lot of those down, but they're absolutely there, ready to step up again in the event that we see a new surge coming. We've had considerable experience in management of the patients. There's data coming out all the time: dexamethasone, remdesivir, the latest one about inhaled medications, all of which is ready to go. We've tweaked the red and green at the front end and within the wards, so that at the moment we have very few patients with COVID, but we can reverse those changes very rapidly and re-implement a much larger red area at the front end of both hospitals and within the wards of both hospitals. We have respiratory rotors ready to go. We have junior doctor rotors ready to go. We have anaesthetic consultant rotors ready to go to cover ITU. So all of that can be stepped back up at a moment's notice. So we have gained considerable experience from what happened before, and within reason, therefore, we are well prepared for a second surge. Obviously, we would not want a second surge to be considerably larger than the first surge, and if that happened, then further changes would have to come into play. But we could certainly cope with something up to around double the first surge if we absolutely had to.
Thanks, David. Vicky, you trying to get in on this particular point?
Yeah, I was just going to say that I you know, since all of this has began, all of us, but I guess especially, you know, the chief nurse, the medical director, and the COO have many conversations every day, and with all of the operational teams, because it is absolutely about all of us doing it together. We have absolutely learned a huge amount that will stand us in very good stead, and there are things that we can stand up and down as we need to. If we do see surges, periods of increased incidence, and we've had some little tiny ones in the last couple of months, then I think we know what to expect now, and our staff know what to expect, and it'll be how we look after everybody, you know, over the winter and through what I'm sure will be a difficult time anyway. But I think the knowledge is there and the experience is there. It's just making sure that we're all kind of, you know, keeping everybody going through the next few months.
Thanks, Vicky. Damien.
Thank you. So just responding obviously to the business case point, I would say it's been surprisingly busy, given that we're not supposed to be agreeing business cases. For a start, COVID-related business cases are going through the process. We've had CellPath back in June. We've had a business case on ENT, which actually was COVID-related. We've also had some major funding coming down from DH Centre. So a big one has been an 8 million allocation that's around critical backlog for estate, which has gone through the ICS. And we are working on 9 million of schemes that are all related to our element of the ICS plan. So actually we are progressing quite a lot, but they're just on specifically targeted and allowed areas from the centre.
Great, thanks, Damien. Amanda, you've been waiting to ask a question.
I have, thank you, Chair. And thank you, Adrian, an excellent report. And whilst I can't comment, I would just like to applaud the work of this organisation. It is so refreshing to see the progress that has been made. I just wanted to take us to the vulnerable that are highlighted in your report around safeguarding, Adrian. And whilst it talks about the actions you've put in place for children in care and also those with learning disabilities, I just wondered if you could expand on how that was working to ensure that we are making sure that we're doing initial assessments, etc. So it's just to bring out that aspect of the report a little bit more for the board.
By all means, Amanda and Vicky may want to comment also. So specifically with reference to the looked after children and the first assessments, there were a number of changed operational practices that were put in place, agreed with social services, which have helped improve the numbers and the rate of first assessments done within statutory time, and that's feeding through to the follow-up assessments as well. So there's a caseload, I think it's around 100 children that team look after, and they've kept very diligently well on top of that, and we reviewed that at the performance review for that division only last week, Amanda. More broadly, in terms of the work for more vulnerable and at-risk children through the broader issues of safeguarding, the health visitor teams have continued their work, but in a very different way. They've done a lot of follow-up, obviously remotely, but they have maintained their contact with families. They have actually found that surprisingly effective for them in the way they've been able to continue to carry out their assessments and their referrals back. So actually the work that's been done has been very good. There is no doubt that the lockdown and the issues around COVID have created difficulties for families and young people who are in stressful or difficult circumstances. There is no doubt of the difficulty of that, and certainly working with our colleagues in SPFT, they are seeing an increase now in mental health and wellbeing problems situation. But our teams have been working through.
Vicky?
Thanks, Adrian. Thanks, Amanda. Absolutely so. And I was dialed into one of our safeguarding adults boards last week, and we've all been, you know, throughout all of this, very aware and very concerned for all of the reasons that we know, the risk in terms of domestic violence and to, you know, very vulnerable children as well. I had a huddle with the LAC team just last week, and they've done an extraordinary job, actually. There's all sorts of things that you don't even realise are a challenge until they present themselves. Issues with dentistry for looked after children, you know, high risk AGP procedures. So they've done an incredible job, and very aware of making sure that we are in contact either digitally or safely face to face with very high risk children and young people. There are some pluses though. So we have seen the number of people coming forward for adoption increase, which is a real positive, actually, because of couples who haven't been able to access maybe fertility services throughout the pandemic. So there are some positives out of this, but for sure, everyone is very, very aware of the challenges when people are in effect locked away. And there has been work that has absolutely carried on in the background, and we're trying to re-establish all of those things in the way that we are for our cancer patients and everyone else. So absolutely top of the agenda.
Great, thanks, Vicky. Thanks very much, Adrian. Let's move on to our integrated performance report and to quality and safety. We start with you, Vicky.
Thanks, Chairman. Indeed. So as always, very happy to take any questions at the end, and I'll hand over to Dr. Walker. But just to pull out some headlines, I think we had a very good discussion at the Quality Committee, but I'm sure Jackie will want to talk to some specifics. But in terms of patient experience, so the complaints process did officially resume on the 1st of July, and I'm very pleased to say that the Trust is in a good position, and the divisions and others have worked very hard to try and maintain response times whenever they possibly could over the last few months. We have had a very small number of complaints about the restrictions that were sadly necessary in terms of visiting. Adrian's alluded to that. Just to reassure the board and the public, we have never at any point banned visiting. I know some of that has been in the media. We never banned visiting, but we did follow the national guidance, and we did have to introduce restrictions. But we had a number of exceptions. Our staff have done an incredible job, and even in the middle of surge, you know, we were able to safely support visitors to our critical care units for patients who were sadly at the end of their life. So we didn't ever ban visiting. We haven't. We have had restrictions, and I continue to review those on a weekly basis with all of our senior teams. And whenever we can safely increase visiting, then we will do so, and we'll keep that under review. Just to thank all of our staff, but in particular the staff that we have on our main entrances. So at Conquest, Eastbourne, Bexhill and Roy, we have our meet and greet service, who are talking to members of the public and patients, who are handing out masks and face coverings and offering hand sanitizer, and that has been very well received. So huge thanks to all of the staff who are continuing to do that, and very well received. When I speak to members of the public, I think they feel very reassured by that, and they're able to have conversations about masks and hand hygiene, which is incredibly important. In terms of safety, so our incident reporting has returned to expected levels in line with our activity, and we did have considerable discussion at the Quality Committee about maternity in particular and medication incidents, and I've spoken to our lead pharmacist Jane Starr, and she's undertaking a deep dive in relation to medication incidents, and we'll bring that to the Patient Safety and Quality Group and indeed the Quality Committee. In terms of other safety indicators, they are detailed in the report. We had 2 falls with harm in June, both subject as always to full root cause analysis, and 1 category 4 pressure ulcer, and again full RCA, and I'm cited on both of those, and they will follow normal reporting process into the Patient Safety Committee. Significant work still ongoing in relation to falls, and we had a very helpful report that came to the Patient Safety Committee, which I've asked to come to the next Quality Committee, which will outline the 4 work streams and all of the quality improvement work that is underway, that we've tried to continue even through the last few months of the pandemic. In terms of infection control, no concerns from me in particular about Clostridium difficile. Year to date, we've had 10 cases against our limit of 22, and post-infection reviews are underway. And actually the MSSA bacteremia that is referred to in the report as potentially avoidable since the papers were submitted has now been deemed as probably not avoidable, and actually what was initially thought to be a urosepsis we think was now an epidural abscess. So again, full investigation in that case. Workforce, I won't say too much, and Monica I'm sure will provide far more detail, but broadly fill rates are normalising and are largely stable as we see a number of areas returning to more usual activity. Just to say that obviously a number of areas continue to run red and green and will need to continue to do so for the foreseeable future. And there is increased complexity in terms of infection control precautions and PPE, but I'm sure Imran will also talk about some of the pathway work when he reports. In terms of COVID, we did have 2 periods of increased incidence in mid-June and mid-July, particularly at the Eastbourne end of the county, and we did see some asymptomatic spread of COVID between patients and indeed between staff. So the numbers will be updated from what is in the papers, but as of yesterday, we have now had 337 confirmed positive patients, 249 patients that we treat as positive, 431 patients who've been discharged, and sadly 128 patients who have died. So in terms of turnaround time for our external testing, is still a challenge for us at the moment, but to assure the board that that has been escalated via all of the appropriate routes and looking at all opportunities for our own in-house testing. Before I hand over to David, I'll just take a pause to see if there's any particular questions for me and any of that, or for David. No questions?
You're on mute, Steve.
Oh.
I was just saying that's obviously all very clear, Vicky. So. Oh,
wow. Okay. Thank you all. David, I'll hand over to you just to talk a little bit more about mortality. Okay.
Thank you, Vicky. So the The next shimmy will be published next week and will be 97 for the trust. 97 is a pretty good result, but it's not quite as good as it was a few months ago, where we did actually peak at 94. Obviously, we have to put this in context. The shimmy was 115 5 years ago and 112 when I took over 4 years ago. And as an integrated trust, we are subject to counting deaths in our community hospitals, which we're compared largely with acute trusts and not integrated trusts. And so having the added mortality in some of our community trusts does sort of drag the shimmy higher. And so overall 97 I think is a good result. However, it obviously isn't quite as good as it was a few months ago, and I've been looking into that. And there has been a very slight increase in excess deaths over the winter period, combined with a slight reduction in the depth of coding, particularly at the Conquest site. And so I've put some measures in place to try and improve the coding levels. Looking at the excess deaths, the only area that I've identified where we are performing perhaps marginally less well overall is actually myocardial infarction, although the majority of those excess deaths in myocardial infarction are not ones that come through the interventional pathway. They tend to be very elderly patients who are not fit to have invasive therapy for their MI. And we have done a deep dive on that in the past, but I think we may need to just look at that again if that signal persists. We are about to come into a very difficult period in terms of monitoring mortality, both with shimmy and with RAMI, because the next set of readings that will be presented are the ones that include the COVID period. Now, both shimmy and RAMI are looking at presenting values both with COVID deaths and without COVID deaths, just to try and make life a little bit easier for us. But even with that, it's not straightforward. So just to give you a flavour, in April, our RAMI, including COVID deaths, will have gone up to 142 from 80, and you'll think, oh my goodness, that's terrible. But in fact, when you compare that with our peers, which is 238, you will realise that actually in terms of excess mortality through COVID, we've done really well. And then in May, I'm pleased to say that we're back down to 91 compared with peers of 140, reading of 140. They've also attempted to strip out the COVID deaths for April and May. And if you do take away the COVID deaths, our RAMI goes down to 101 for April and 74 for May, compared with national readings of 115 and 105. So again, much better than our peers. But you may ask why, when usually we have a RAMI of mid-70s or 80, is it 101 for April without the COVID deaths? And I've been giving that some thought. And I think it probably reflects two things. First of all, in April, there were certainly some COVID deaths which tested negative for the swabs. We know that the swab testing is only 70% accurate. And so I think some people early in May died from COVID and did not go down as COVID deaths. So I think there were some excess deaths there. And secondly, the issue which has been discussed at great length in the newspapers and on television around the fact that people delayed their admission to hospital during this period. So people were very concerned about coming in because of the number of patients in hospital with COVID. And so myocardial infarcts presented late, strokes presented late, people stayed at home with other forms of sepsis. And then when they finally did arrive in A&E, they were sicker than they would perhaps normally be. And therefore, I think inevitably everybody's mortality rate for that period, even for the non-COVID, is going to be slightly higher than it would normally be. But the only reassurance of that I can give you is that our readings for the RAMI in each case are considerably less than those of national averages and of our peers. Moving on to the COVID page, Vicky's already given you the latest update on the top left graph about numbers of admissions or diagnoses, discharges and deaths. It was interesting that by June, COVID had dropped to 4th place in terms of causes of deaths and was considerably down on pneumonia and cancer. So getting a much more normal picture of in-hospital causes of deaths. And then finally, I've given you at the bottom left, I've given you an update table on lower tier local authorities as of the 19th of July when we put the slides together, showing that out of, I think, 200 and something lower tier local authorities, Hastings has got the lowest deaths, Rother was 23rd and Eastbourne 52nd, so all very much in the top quartile in terms of overall deaths. And I think that reflects two things. One, it reflects the fact that we have had low numbers of COVID in our area. And secondly, I hope it reflects the fact that the ones that we have had who have been sick and in hospital have been cared for very well. And we put all of our surge rotas in place, and we had a really high quality anaesthetic response on ITU. So the sickest patients had a mortality which was much less than the national average. So I'm happy to take any questions on that. It's a bit complicated, some of the changes coming our way in terms of RAMI and shimmy through this period.
But thanks, David, that's really helpful. Questions?
Well, I've satisfied everybody's curiosity, or I've blinded them with science so that they don't want to ask me anything.
Or a bit of both.
A bit of both.
Yeah, thanks, David. That's great. Shall we move on to workforce, Monica?
Thank you, Steve. Firstly, apologies. I noticed yesterday morning that the figures that have been included in the pack were for the previous month. The business development department, I think, picked them up by mistake. So they were previous month, but Peter has kindly circulated the correct month's figures to you. So I hope you've got that in front of you. To start with, in terms of staff usage within the month, in terms of the cost of our workforce, it was slightly down on previous months. That was in spite of having an increase of substantive staff, which was good. That was because we had a decrease in the amount of temporary staff we used, particularly the use of bank staff. Also within month, our vacancy factor went down. Our vacancy factor is generally quite low considered in comparison with other similar trusts. Our vacancy rate is now 9%. As Adrian said in his report, we have had some good recruitment going on in spite of COVID, particularly for medical and dental staff, which is our area which has the highest vacancy factor, which is around 18% at the moment. We've had new consultants coming in histopathology, radiology, and all grades of emergency medicine, so that's been really positive. We are having some difficulties getting staff coming to join us from overseas during this time, apparently due to visa requirements. But we've got 12 radiographers due to start in October, which again is really good. And another cohort of international nurses also joining us later in the autumn. And so that will be really positive. So there's some really good work going on with recruitment. And for most of the posts we advertise now, we do see a large number of applicants, so that's really, really important. Turnover has remained unchanged. That's at 9.8%, and again, that's very positive compared with other similar trusts. Moving on to sickness, again, there's been a positive move within the month. Sickness has reduced by 0.7% in the month. It now is at 3.9% for the month. And when you look back to April and think our sickness was at 5.4% in April, that shows quite a reduction. That is in areas, for example, reasons for sickness such as coughs, colds and COVID-related illness, as you would expect, but also the amount of sickness due to stress and anxiety is down in terms of previous months. So again, I think that's really positive. And I hope there's some correlation there between all the good work we're doing in terms of supporting staff. Both appraisal rates and mandatory training rates have gone up in the month. And again, that is really good because there are areas that we don't want to ignore, because appraisal and mandatory training are really important for staff, both for their own development and for health and safety. So that's really good, and I'm pleased they're up. At the moment, we're very busy. We're going through the induction of all the new doctors. We've got 120 new doctors. The induction for the new doctors is ongoing. And indeed, we've revised our induction programme to fit it in line with the new requirements around social distancing. We spoke earlier on around the wealth of health and wellbeing initiatives, right? underway, and they're ongoing in terms of check health clearances for staff, checks, psychological well-being, support for staff that are having difficulty in their roles as carers, either of elderly parents or with children and childcare needs within this time. So again, that's good. Job planning, again, good progress there. We've now got 87% of our consultants with an up-to-date job plan, and 75% of our other doctors are other grade doctors, so that's really good progress and a lot of efforts being made in that regard. We're also working with all the divisions to make sure that we've got specialty-based workforce plans in place for each area, and I think that's really important, linked to activity as we move forward. The National People Plan was launched last Thursday, and I will be taking a paper on that to the next pod meeting, the People and OD Committee, which is in September, and then that will come to the board. But I think that's really important. It follows up on the interim People Plan that was published last June and really sets out the focus for people management in terms of both systems working and individual trusts for 2021. There's 4 really main tenets of that People Plan. One's around looking after our people, which is all around health and well-being, as you would expect. Another one is belonging to the NHS, which largely is around equality and making sure everyone feels involved. The third area is around delivering new ways of care, and that's around new roles, upskilling, extended practice, etc. And the last is around growing the future workforce, which again is really important because that's around recruitment. And I think that's really important to note because that really links in with our own trust workforce strategy that we launched this year that covers all of those things, and we've already made significant progress in all of those areas. The final point I'd like to talk about is the health and safety risk assessments for staff that we're undertaking. Obviously, these are about protecting our staff who are working in this difficult time when we've got the pandemic ongoing, but also because we've had a national requirement to undertake risk assessments by NHSI, who asked us on the 8th of July to carry out risk assessments and to report back nationally about risk assessments for numbers of our staffs. And these were any staff who were Black, Asian and minority ethnics, any male staff within the trust, any staff that had underlying health conditions, or any staff that were pregnant. And for us, that equated to over 5,000 staff that we were asked to do risk assessments. And when you think that was on the 8th of July, I'm now very pleased to be able to report that for all staff, we've done 61%. For at-risk staff, those in those at-risk categories, we've completed 87%, and for staff that fall in the Black, Asian and minority ethnic group at 77%. So huge, great progress in 3 weeks, which I think is really important. And also to note, I think that some of our staff are telling us actually they don't want to be labelled in this way, so we're having to be really sensitive in terms of how we're handling and recording that. So, but again, this is around making sure we provide a safe and secure working environment for our staff. That ends my report, but I'm very happy to answer any questions if anybody's got any.
Great, thanks, Monica. Miranda, did you have a hand up?
Monica answered what I was going to ask in her commentary,
okay.
So I took it down again. Thank you.
Thanks. Okay. Amanda?
Yes, great report, Monica. Thank you very much for all your work and that of your department. I just wondered, the additional support that we put in place to ensure that staff are cared for during the stress of COVID, how long do we envisage that additional support being in place? Are there contingencies for a second wave? And secondly, I just wondered whether or not there is a way or what consideration you've given to assessing the impact of that additional support so that we know how to target support going forward.
Thank you, Amanda. They're really good questions. I think firstly, in terms of the ongoing support, I think this trust was probably ahead of some trusts in that we made a decision to invest in kind of organisational development, health and well-being of our staff quite a long time ago, and that was part of the work we did around looking at culture and organisational effectiveness, really. And so we have got an established health and wellbeing team, really, who actually had started to do all these things and have all these things in place before actually we had a pandemic. And I think in some ways what we've done in terms of culture and looking after staff actually probably was one of the factors that helped us cope quite well in terms of when we did have the pandemic. So therefore I will foresee those things will be ongoing, and I'm really pleased that they link very closely to what's in the people plan as well. So I think that that is really important. Your second point about monitoring the impact is also really good, and we've given a lot of consideration to this. There are a number of things. There's obviously things like sickness rates. There's engagement scores through the staff survey and ongoing engagement, really. There's a number of people that speak up to our Speak Up Guardian and feedback for staff. There's a whole wealth of things, but we will be doing a report to go again to pod to try and really assess what the impact of the support we've given has been.
Great, thanks, Monica. Vicky?
Thanks, Amanda. Really good questions. I'd repeat Monica's, and some of the conversations I've had over the last few months with colleagues from the forces. Actually, we had some great webinars, them feeding back their experience about how they look after their people in prolonged traumatic, intense experiences, which this certainly qualifies. And I think it may well be for quite some time, actually. There'll be some staff that have exhibited anxiety, depression, post-traumatic stress already. Some may go on to do that over the next few months, but for some it may be years. I've certainly had a number of conversations with colleagues around the trust, and I think we've seen some anxiety in people who've never experienced that before. It's also on occasions been a trigger for some people who've had previous post-traumatic stress, but I suspect that's true for a lot of people globally. So we're very, very alive to that, and I think the work that Monica and her team, and especially the occupational health team, have been doing is just extraordinary, and I'm very proud of the focus that we've had in taking care of our people.
Thank you. Nikki?
Thank you, Chair. Monica, first, well done on your progress on those risk assessments that are required. It sounds like you've been making really good progress, and it also sounds like you've prioritised, so thank you. Are we getting an indication yet of the impact of the outcomes of those risk assessments? So potentially, are we seeing sort of staff numbers that we may have to redeploy differently if there is a second wave, and how are we planning around that?
Yes, I think we've learned a lot from that, actually. There's some staff that are still not able to go back to their substantive roles, actually, and we are having to work with them closely in thinking of other ways. So, for example, can they work from home? Can they work in another role and things? So we are learning a lot. I think in terms of ways of working, this will totally change the way we work in lots of ways as well, and we will have a much more agile, flexible workforce, and we will be using, like we are today, technology and things a lot more. I think we'll also be having to make, and we are indeed making, lots of changes to the workplace in terms of making sure that staff are safe, that, for example, staff can socially distance if they're not wearing PPE and things like that. So there's a lot of ongoing changes and adaptations that we're having to make, yes.
Great, thank you. Shall we move on to the next section, Imran?
Thank you, Chairman. So I'll briefly cover the salient points from the report with some detail, and obviously I'll be opening up to questions and answers after. So just to echo everything that's been said so far, the team have really risen up to the challenge across the organisation, and that's palpable. And when I went round as part of footfall control with the site team over the weekends, you could actually feel and sense the focus around patient safety, patient care, and also colleague well-being. And Monica, Vicky's already mentioned around the meet and greet team, and they were present during out of hours as well. So that was really impressive. And certainly as a new member of the team at the time, I noted all those observations as I went through and walked the organisation with colleagues. So in relation to emergency care, just starting off there, we still have our red and green areas around COVID management. There are occasions where this clearly causes delay. Particularly, there's a trend and pattern that when we have attendances over 10 an hour in particular, and also out of hours, that it does put strain on the team, but that is generally being managed. And when it's not, like last night as an example at Edge, that's being reviewed, and we're looking at it through with the doctor in charge and the nurse in charge around a safe way of managing that collectively. But patient safety is absolutely paramount at all times, and we are supporting the teams to ensure that message is filtered down at all times as a way of practicing. So in relation to A&E position, for June, we delivered 95.2% of the 4-hour patient access standard. That brought us 36th nationally out of 114 organizations across. And our current position as it stands, we're at 92.6% for July. So we're still maintaining the above 90% position steadily. Attendances have started returning to pre-COVID levels. And particularly last night, as an example, Edge received 208 attendances. So we are keeping an eye on that, and we're managing that and supporting the teams through managing those numbers as we go through. We're also working very closely with our ambulance colleagues, so CCAM, and I've had a couple of meetings with them, and we're going to constantly keep it under review around our ambulance handover times and ensuring that safety element of handover and working closely as we go through as part of our partner agency working. So in relation to our emergency care, the plan really is, we've already had frailty mentioned, Adrian's mentioned that, and David's certainly been encouraging that from a clinical perspective with our clinical colleagues around strengthening that. So frailty, it plays a really important part, and we're going to continue working on that as part of our patient flow improvement program. At the Conquest, we are going to be focusing more on the front end elements of the pathway of the patient flow program, really making that robust and maintaining and strengthening the back end in terms of our discharge position. In Eastbourne, we're going to share some of the practices around the front end to reduce variation across the sites in particular. And whilst doing that, we're also focusing with our partner agencies around the discharge component and strengthening the medically fit for discharge patients, for example, and how we manage that cohort consistently to ensure that there is that flow maintenance across the board. But what's key for us is that we share best practice across both sites. We have that standardization work as part of patient flow program and effectively reducing the variation across the piece. The patient flow program currently is being reviewed. We've updated a few things, and also bearing in mind the COVID position currently and also the winter planning, it's really critical that we have an integrated approach. So Joe, myself, the wider team, Vicky, David, we're very clear. We don't want lots of mini plans. We need one plan, one approach, integrated approach that we're all looking at and we're all monitoring as part of our executive assurance, so we can obviously provide assurance to the board. We are looking at our length of stay, noting that there is very, very tight scope there in relation to upper quartile, but we are looking at that. We are improving. There's no room for complacency, and we are planning to see if we could actually consistently hit the upper quartile, particularly as part of our winter position in our capacity management. So winter plan is currently being refreshed in light of the national guidance that Joe has also alluded to. I'll let Richard cover the details around that as part of our recovery and restoration and recovery section of the board papers. And we're also reviewing our escalation standard operating procedures around ED, 2-hourly huddle, making sure that the nurse and the doctor in charge are absolutely empowered to ensure the oversight across the departments and the safety of it and managing that in pressure supported by the site team. So it's tightening the processes we already have in place, all the blocks that we have in place, but just arranging that so that it's very clear and consistent. In relation to planned care RTT, for June, we delivered 68.6%, which made us 6th out of 112 in terms of ranking nationally, which basically just reflects the symptoms of post-COVID on our planned care in particular, with the first phase where planned care was compromised, and rightly so, in terms of patient safety and patient care focus and prioritizing care, but that clearly now has left us with a backlog. And we've never had 52-week breach of the standard, what we have now. Unfortunately, we have 170 patients that are on the list. Every single patient is being in relation to clinical harm, including for cancer, where we've got some 104-day patients as well. And so they're all being reviewed clinically. We are managing the patients, and we are absolutely going through clinical urgency as a priority, followed by chronological weight. So there is that equity in terms of access and consistency, and we also report that externally via the ICS systems for assurance. So July position currently is 59.4%, so it is a deterioration, but bearing in mind that we are having additions to our 18+ week and 26+ week position faster than we are actually removing, because of our current activity levels being 60% of our pre-COVID levels. So we just need to be mindful of that challenge that we're working through. In relation to cancer, we delivered 66.3% in May, and our current June position is looking better at 78.5%. And July position, we feel, is probably going to be around 73%, because we're constantly getting ourselves into an anticipated stage as opposed to reacting stage. So we're kind of seeing that trend, but a big caution here in that our diagnostic weights have gone up. Our diagnostic waiting list has doubled, in particular due to the COVID position and the restrictions around that, particularly areas like endoscopy, because of the aerosol generating procedure risk. That's pretty much limiting the numbers that we can put through, because it's also about protecting patients as well as staff, and obviously the PPE components does tend to slow things down, particularly in theatres. So overall, 104 days, we are currently at 76 patients, bearing in mind we started with 100. So it is reducing, it is going in the right direction, and we are trying to speed up as part of the prioritization process. As I was saying, August and September is a high risk because of the diagnostic position. And at this point, I'll just share the diagnostics, which is our DMO1 standard in the board report. That's currently sitting at 32.8%. Now that should be 1%. What that's telling us is that 67.2% of our patients are seen within 6 weeks. The remaining 32.8% have breached the 6-week standard. Again, we are prioritizing clinically the cases and making sure that we follow the standard approach around P1, P2, P3, P4 as per nationally determined guidelines. The next stage then is around our restoration and recovery. In relation to outpatients, our recovery plan was set, and we've currently delivered 3% above our recovery plan. Now, having said that, to put it into perspective, we've only delivered 60% against our contracted levels. So we are behind what would be expected in terms of our contract levels. So the pressure continues, and we are predicting that if nothing changes between now and September, the cumulative delivery would be 62.4% of our contracted levels for outpatients. Bearing in mind that the Simon Stevens letters come out, and the expectation is that we would be ramping up to near normal levels for outpatients in particular by kind of October time. Now, that is predicated on 60% of our follow-ups being seen on a virtual basis as opposed to face-to-face consultation. I think we're kind of primed for that in relation to the changes that we've made to clinical pathways, which Vicky's alluded to as well, because there have been changes along clinical pathways that the colleagues have tailored really well. We need to strengthen and support that going forward, and that element of the guideline will support us with that. In relation to elective care, We are 9% below the recovery plan currently, and 53% against our contracted levels. Of the 53%, as things stand now, 45% of inpatient activity has been delivered against our contracted levels, and 55% of day cases, because you would expect day cases to be higher. But bearing in mind there are still restrictions around patient proximity and all the other variables, including theatre access and the turnaround times between theatre cases, particularly around donning and doffing, etc., putting on PPE. So overall, I think with the position, we do have a challenge around our winter, where we've included 6% growth under business as usual. So that's one element that we have to clearly manage and plan for, and we are doing that. There's a second element around COVID-19, the current position, and then potential surge, which we've modeled to ×2 currently along with the system. And the third element is the elective backlog, which we will have to prioritize clinically going into the winter. So with these three components, what we are maintaining in terms of our messaging to the teams is very clear around patient safety being paramount, around the people plan being absolutely critical because we need to look after our colleagues throughout this, and meeting the regulatory requirements as well. So it's a tight balance, but it's one that we have to do, and that's the challenge for all of us, including the exec teams. I'm ready to take questions now. Thank you.
Great. Thanks, Imran. Start with Jackie.
Thank you, Imran, and the other presenters. I'm amazed we've done as much as we have done, given the restrictions we've got on ourselves. But I think I'm just seeing a bleak future. You know, we have got increase in stranded patients. We've got an RTT that's deteriorating. Our diagnostics are nowhere near. I don't know how many of first appointments are then adding to a diagnostic wait list, because I'm sure we can't send people away just on a first appointment. So I'm presuming there will be a delay after the first appointment to get diagnostics. And also there's A&E breaches now, and that's with all the effort we're making. So I'm just wondering what could be the biggest change we need in order to get this caught into this pint pot, because I can't see that we can do it. It's just too much activity through too little capacity that for us to really get anywhere near what we were doing before, which was already being overworked in terms of volume. So I'm really pleased with what we've done, and I've taken great assurance for what we've done so far, but I'm mystified as to how we can improve the future without something major happening, and I'd be interested in what that major thing could be.
Okay. So if I take that, and Joe and the others might want to add, but from our perspective, I think the first key thing, Jackie, is you're absolutely right in terms of the achievements that the teams have made, which is why I keep emphasizing maintaining and strengthening. That's the key message to ensure that there's that consistency across the organization. The key thing here is that we are not on our own, and we can't do it on our own. We are part of a big system. So it's about having that clear dialogue. So regularly I'm linking up with the other chief operating officers across the system. We're also linking up with our integrated care system partners as well, ensuring what could be done and what could be shared. And in relation to that, the medically ready for discharge, we have actually worked on a very clear system-wide escalation process, because there's no room for complacency, and we need to be monitoring that, including the stranded patients, as you've put, because not only does it impede flow, it's actually not good from patient quality perspective. So it's looking at that, and as part of the system, creating capacity in the community. So whilst we've put our bid in for CCAL capacity, for example, what we're also looking at currently, and I've actually, Damien, Richard and I are meeting up on Monday to go through some of this in a bit more detail, around community capacity and how we could actually put something in place now whilst we wait for CCAL decision. Joe might want to add something, I can see, and Richard as well. They both got their hands up.
Yeah, Joe, do you want to add to that?
Yeah, so I certainly won't repeat what's said. I think I'm going to turn it round in a slightly different way, which I can now. I'm not the coup. So my question is, why can't we do
100. So if we take outpatients, why can't we do 100% of outpatient work that we were doing pre-COVID? We might do it in a different way, but we do need to be able to put those services back. And I think we can deliver the best part of 100%. That doesn't necessarily clear all the backlog, but we should be able to at least get back in line with demand. I think what we need to focus on really clearly over the coming weeks and months, and we are going to get a bit of support to help us with outpatients, is around productivity and doing things differently, moving to things like patient-initiated follow-ups, and where it's appropriate and we can close off an appointment with a non-face-to-face, then we should do so, not just do them because it's non-face-to-face and then bring somebody back afterwards. So I think we've really got to push on the productivity. We do have access to the independent sector. Now, that doesn't necessarily mean additional workload, but it does mean additional space and some additional theatre staff, which can support additional capacity. As Imran's alluded to, what we're trying to do across Sussex is pull together a Sussex-wide plan, or planning tool, if you like. So if we can manage things at a place level, then we will do so. If we genuinely can't get back to some sort of reasonable operational plan, then we will need to look at more innovative ways across Sussex and look at either mutual aid or look at more strategic options. So it might be that we need to look at a diagnostic centre or something like that. I think the challenge is probably more of the challenge actually for me is probably around our electives, where of course we're looking for anaesthetists and our theatre staff to support ITU, and at the moment they're relatively low levels of staff through ITU, but whilst we can, we need to utilise those staff. We are obviously trying to work out a different way around, which is actually what would it take to get back to 90% activity for our electives and day cases, and then we'll have to work through from a finance perspective how we do that. But in summary, I think there's quite a lot for me about increasing productivity and new ways of working. I've got one other point that I want to come back to on non-elective, but I don't know if you want me to come back to that, Steve, separately.
Let me just check with Richard. Richard, are we going to cover some of the kind of forward look points in your paper?
Yes, we can do. I mean, I was going to pick up with Joe's point really about to answer Miranda's question about not Miranda's question, to answer the question about caught into a pint pot, Jackie's question. I think it's about presenting the best plan you possibly can, and it's about the coherence of the planning through the submission process at a regional level. I think we're going to have to, this is what we can touch on, some of the conversations Imran was alluding to around showing our working. So we know what we need to do in terms of our activity levels operationally. How does that fit with the workforce that we think we can get access to and the money and the envelope? That planning is in its infancy, but we can certainly talk through when I give an update around the areas that we're going to be looking at over the coming weeks.
All right.
Or days. Yep.
Thank you. Joe, did you just want to come back before I go to Miranda? Do you want to just come back on the non-elective element?
So there is something, again, this is about doing something different, and we've got permission to do things differently. Both we've given ourselves permission, but also there's national permissions to think really differently. One of the things that we're doing, and I can't remember if I picked up at the last board, is that we are going to be a fast follower for 111 first. So Portsmouth are piloting a booked process, if you like, from 111 and the CAS, the Clinical Assessment Service, based within 111, to try and reduce the footfall coming to ED. So we're going to, it's something we need to do across Sussex, it's something that needs to be done nationally, but East Sussex is going to be a fast follower with support from NHSE. And we are expecting by October to have electronic booking systems directly from 111 and the CAS into a number of endpoints, and an endpoint being a service or a point of contact with a patient where we can support that patient's needs at that point and close that contact. So that might be non-face-to-face or face-to-face. So wherever possible, we're trying to avoid people to come into ED, and if we do, then they come in on a booked basis. Now, clearly there will be some life-threatening conditions that need to come directly in via 999. There'll be a whole range of patient communication around that, and we're really only just starting that process at the moment. But for example, that'll be booking patients into the UTCs, into primary care, into acute hot clinics, mental health, social care services, but doing that on very much more of a planned basis. So it's about having those alternatives in place, really, and then it's about making sure patients, for urgent care needs, ring 111. I'm not saying that's going to be easy, but actually that is the game changer, where really what you talked, you don't have walk-ins at your front door. Everything comes through on a planned basis. So it's a very big cultural change. It's going to require national and local communication and support to do that. I'm not expecting it to be magic by the 1st of October, but it's a once in a lifetime opportunity to change the way we manage urgent care. So I think it's really exciting, and I'm going to keep the lead for that because I think it is it's such a huge opportunity. So I thought I'd just share that now.
Right, thank you. Miranda.
Thank you. A couple of things from me, really. One was I welcome the level of detail in this report, because the impression you get from the summary sheet symbols at the very front of the whole IPR is quite different, I think. So if I pick on 4-hour A&E, for example, the summary relates to the in-month variation, and you get a very different feeling from that than you do from going into the detail in this section of the report. The second point I wanted to make was that basically my question was a mixture of Jackie and Joe's contribution. So it was Jackie's list of concerns combined with Joe's why can't we approach. And I'm very assured to hear what Joe said about the national permission to do things differently, and the fact that we're embracing that. I think that's really excellent. So I look forward to seeing the progress that we make in that regard. I think in addition to the system-wide approach and the fact that we're not alone in this, that's also been mentioned, and besides the national permission to think or do things differently, there's also been a comment in the press over the last few months about actually changing the targets or losing some of the targets altogether, and I wondered if there was any kind of update on any of that.
Imran?
So I'm mindful of that. It's one of the first things. The moment HSJ released that, it came ping on my mobile and I shared it with colleagues, but we haven't heard any more. Certainly not that I've received anything that I'm aware of.
Joe?
Yeah, I did ask colleagues external to the trust if we had any information on that, and we hadn't. The change or proposed changes came out about a year ago, maybe even 18 months ago, and they've been trialled in a number of organisations, but there's certainly not been any advance notice of that. What would be very difficult as well is that our systems are not set up to measure in that way, but obviously we're intrigued. We know what they probably would look like, but whether they'll be in for this winter, yet to know. I think the important thing is if we focus on timely access to care for patients and doing it right, how we measure that sort of comes as at a later point, really. But if there is any more, we will share that in due course.
That's good. Thanks, Joe. Amanda?
Joe, really a question to you, and thank you for such a really helpful update in terms of 111. I just wondered, given that a lot of this is about behavioural change, both as a local system in place and as an organisation, you mentioned that communication was at its kind of infancy, its starting point. Can you just help me understand what that would look like and how we use the next few weeks to really work with the public, our patients and our primary care colleagues to ensure that we are working as one at place?
So I think we are absolutely in infancy. Some time ago, probably a year ago, we did what applicant, why come to A&E, why come to our front door audit. And there were lots of reasons, and I'm happy to share that offline because we've reported that back here before. And I think it was really interesting during the initial COVID sort of few months that we saw a 50% reduction in walk-in patients. So, but that has bounced right back up again, which I'm slightly surprised by, but perhaps I shouldn't be. I think what I'll need to do is come back to you and answer your question more fully. We are going to learn and build on what Portsmouth are doing around the public communication, and we will build that over the coming weeks with our comms teams across Sussex and at place level. So it's not a great answer, but we will work through that and perhaps update at the next board, and even perhaps, you know, if we need some time at a seminar to talk through that, we can.
Right. Thanks, Joe. Shall we move on to finance? Damien?
Thank you, Steve. Okay, can I start with an apology? It's always a good way to start. So there is a slight difference between the briefing that I gave to the Chief Exec's report and this report. We had initially believed that our results would be 9.3 million deficit for the first 3 months. Actually, what happened was some of the claim we were making towards COVID had been challenged with the NHS E&I. So there ends up a bit of an adjustment from the beginning of month 2 to what we finalised in month 2. So our final position was actually a 9 million deficit, as is in the finance papers. There are two components to this. Basically, there's the 5.3 million shortfall on COVID that was funded directly from NHSI, and then there's 5.3 million, and then there's the 3.7 million shortfall on income, which again is funded by the NHSI as a what they're calling a true up back to break even. Richard's going to go in detail some detail in terms of the revised guidance we received on Friday. But what we can see so far on the finance side is this payment back up to break even is going to continue through to month 5 and month 6. That there then will be some adjustments going into month 7 and onwards. And I suppose there might be a question of having a bit more control over what gets allowed for COVID payments and what gets allowed for the block contract from last year. I'm sure we'll receive more detail going into the next 2 months, but certainly there will be a change of pace as from the 1st of October. In terms of the other figures, I think what my focus would be is on run rate going into next year. Basically, you know, we had a 28.5 million issue that then got funded through sort of national support mechanisms coming through from last year. That problem will resurface going into next year in some form. So our challenge is not to make our run rate any worse. So while we don't have a direct savings target, a CIP target for this year, there is a focus on making sure that we maintain no increase in costs on our run rate, I believe. Sorry, shall I stop for a second because I can see Adrian wants to come in.
I suspect Adrian is going to clarify what the national support was.
Yeah.
Well, partly, and sorry, Damien, I didn't mean to interrupt. I was just going to reinforce a couple of points. So 2 years ago, we agreed a 2-year set of targets with the central team because of the previous position of the organisation, and on achieving the agreed plan, that triggered, exactly as you say, Damien, the payment from the sustainability and transformation funds and the financial recovery funds, which have come in to give us the break-even position. And the second part of the year of the control total system was to get to a operating deficit in the current year of 24 million. Last year, we set ourselves a target of achieving a 2 million per month deficit run rate by the end of the year. And that compares, for a number of people who will remember this, a few years ago to a run rate of 5 million deficit per month and deteriorating. So we achieved the 2 million per month run rate, and Damien's point about focusing on the run rate is of crucial importance. It's that run rate which is key. And in the absence of COVID, we would have been absolutely confident, and we're setting internal targets of getting that 2 million a month deficit down further, and certainly meeting this year's financial plan and control total with the centre, which would have triggered a further payment. We're continuing to make the point internally, and the internal financial control mechanisms that we had set up have evolved now into the Transformation and Efficiency Committee that we've established to ensure that we remain focused on the operational efficiencies and the cost effectiveness of what we're doing. Because what we want to do is emerge from this interim financial regime still on a month-to-month operational position, which is better than the 2 million run rate that we experienced going into it.
Thanks, Adrian. You're on mute, I think, Damien.
Yeah, so thank you, Adrian. Just to be clear, I'm not trying to be critical of where we are now. I think it's worth noting that with the new guidance that came in on Friday, while to date we've been getting used to, we're basically going to be topped up to get to break even on finance. We're just beginning to see the return of some controls coming in for the second half of the year, I suspect,
yes.
Which is why I'm trying to flag the issue.
Quite right.
So it's a very high level summary of where we are, and let's start to focus on where in particular the manpower manages to stay, because if we get new people in just to replace vacancies, that's actually a good thing in terms of run rate. I think what we would also need to watch is if we can't really fund a total increase in establishment, because we're basically based on last year's establishment. So that's just the bit that I would point out in terms of maintaining run rate. The other point I wanted to make was on capital, although we began to cover this actually in Adrian's section. So we've submitted a plan here for 33 million. Just to be clear, that's the 24 million of our internal capital plus bids for the 9 million of system capital, where we've actually submitted the business cases in draft to NHS E&I to get approved, and it was already part of our annual plan. On top of this 33 million, there was also the 8 million that I mentioned earlier, which was a release of the Prime Minister's funding of bringing early work forward for the HIP project. But that hopefully will come through in terms of the next month or so, so we can actually adjust the plan as soon as we've received the capital. I think I'd like to leave it there for questions, if that's okay.
Yep, thanks, Damien. Miranda, do you want to kick off?
Yes, I just had one question, which is on the divisional summary. I think it's income and expenditure. I wondered why, for all the divisions, you got basically the variance as naught at the bottom, despite the different variances above, but except with few exceptions. I haven't got it right in front of me, but I think, for example, in corporate, you do have the variance shown. I wondered why you presented it that way. I don't know if that is clear enough for you to follow.
So I'm not convinced it's helpful, because basically what we're doing is we're managing to, the COVID shortfall against corporate as a whole, and we're just trying to reinforce the message by division that what they need to do is focus on costs at this stage, and when they incur additional COVID costs, we need to be able to capture that payment separately. So I think the divisional report should just be used as a comparison of cost, if you like, and within that I should really pull out how much of that underspend or overspend was actually COVID related. So it's not ideal, but that seems to be the only way that we can address a block contract at the moment.
If I may just add a bit, in the past, under your predecessor, there's always been a bit of tension about examining divisional finances and trying to gain assurance about how they were performing. So I'm not sure if putting in the nought, as you say, is necessarily helpful, because I think the NEDs definitely feel that they need some meaningful figures, and then they need the ability to interrogate them, really.
So Miranda, I agree with you.
Something to talk about in FNI, isn't it, really?
Yeah, so I agree with you, but I mean, perhaps Adrian will reinforce this. I've started a process, and in fact worked with Richard on it, to go through a forecast to year end with the divisions, and I've had a first meeting with each of them. It's common. What we basically realised that nationally we would be asked for how we would recover to near normal. So what we wanted to do was build a model that we could base a plan around. And so, for instance, I can see emergency medicine is working below capacity, and frankly, that's why we can't claim all of their costs against COVID, because some of it is under capacity. We have a specific issue with community, where we had a plan to increase above last year's capacity, and what we need to do is make sure the CCG are reminded of that before we recruit the additional posts. So what I need to do is give you a plan by division based on how does the model change to year end, and within a month or two that will be ready. I need to first check with the exec team that it makes sense, and also check with the national guidance that we've just received about how we get to 80% or 90% of activity and stay within last year's funding. And presumably there will be a follow-on exercise of, if we can't, will there also be some national resource we can bid to try to get closer to that standard. So those steps absolutely we're going to do, but it will make more sense in terms of the forecast as we move to a specific target, and yes, we will have that within the next couple of months.
Thanks, Damien. Adrian?
Not a great deal to add, because Damien's explained it really well. Miranda, it was merely your reference to the past, because of course Damien wasn't here for those times, and we have gone backwards and forwards a little bit on how we represent divisional budgets and targets and performance against those. Damien and I have discussed this at length through the time, and as Damien said, the work that he and the team are doing to restate the budgets for the rest of the year is coming through. I think the financial regime we've been under through this epidemic has been extremely helpful and important, because it's allowed the divisional teams to focus on the massive response to the epidemic that they've been mounting, while maintaining an awareness of the importance of cost control and cost management. It has required us to think through how do we represent things in this very different financial regime we're currently under. So just as Damien says, he and the team are working through all of the division and corporates at the moment in order to restate budgets for the second half of the year, and we'll be approving those in the near future.
Great. Thanks, Adrian. Any other questions for Damien? If not, thank you. We now have a scheduled 10-minute break. So I make it 12:15, prompt start at 25 past. Thanks, everyone.